Hi, I'm Dr. Asir Mahmoud. I'm speaking to you today from Exeter in the UK. I have a PhD in pharmacy practice, and currently I'm postdoctoral fellow researcher at the University of Exeter. Today I will talk about the DREAM project that I'm working on as a part of a multidisciplinary team from different backgrounds and experiences that's led by Prof. Victoria Goodwin and Prof. Julie Whitney. DREAM is abbreviation for Digital and Remote Enhancement for the Assessment and Management of Older People Living with Fragility in Non-Hospital Settings. I will start with a brief background about Fragility and CGA before describing the plan of work for DREAM. I will talk about the research question and objectives of a DREAM. Then I'll present the work we did, current work, expected impact, future work, and at the end I'll leave you with Prof. Julie Whitney, who will answer the questions. Any questions that you have. As we get older, for some, this means having several health problems, difficulties doing things around the home or getting out to do what's important. There are 8.5% of people around the world are aged 65 and over, and this percentage is expected to jump to 17% by 2050. In the UK, the population is aging with 26% of the population predicted to be over 65 by 2041. Also, among those aged 65 to 95, 13% are living with moderate or severe frailty. Frailty is a clinical term that describes the loss of our built-in reserves, leaving us vulnerable to small events such as infection or a change in medication that results in falls, disability, hospital admission, or any need for long-term care. Typically, there are many complications of frailty, include delirium, falls, disability. People living with frailty and their caregivers have a lower quality of life. A recent UK study that conducted by reviewing 100,000 primary care records of older people found an increasing frailty was associated with healthcare costs in the region of 5.8 billion per year. Comprehensive geriatric assessment is a process used by health and care staff to identify and help manage some of these challenges and help prevent new problem arising that trying to decrease patient admission to hospitals or going to a care home. What is comprehensive geriatric assessment? It's coordinated, multidisciplinary, and multidimensional process that's usually aimed to recognize complex and multi-level problems of older people living with frailty. Rather than a specific action or set of actions, it's about identifying the unmet needs of older people living with frailty, planning and coordinated a tailored program or management plan to improve each patient's life and to reach better outcomes. Therefore, CGA is a complex intervention that involves 4 key assessment domains, which is physical, functional, psychological, and medication review. We worked and we're working with patient-public involvement and engagement and health and care professional stakeholders to develop this research. We involved stakeholders including older people, carers, families, and healthcare practitioners from different backgrounds. The rationale for DREAM project. We found that there is a paucity of high-quality evidence of CGA undertaking in non-hospital settings. So traditionally, it has commenced with those admitted to hospital led by geriatricians in face-to-face consultation with input from a multidisciplinary team. Less frequently, it may be led by a GP, nurses, or allied healthcare professionals. The patient may see several members of the multidisciplinary team in a single clinic or in separate appointments, and may be referred for other investigations or interventions such as rehabilitation and other appointments. There is a limited evidence about conducting CGA in primary care settings. We are interested in a primary or community care-based CGA because even before the pandemic, many older people found it difficult to get to the hospital, and the appointments only give a snapshot about a person and their circumstances. We want to see if we can enhance assessment and management at all, and we plan several ways to do this. How can we do things differently, or using technology and remote assessment, or it may involve different professionals leading to the care or something else. We aren't looking to replace face-to-face care, but we're looking to see if we can do things differently. Providing remote CGA is one of the options. Usually remote care includes contact between a patient and the clinician using telephone or video, and also include remote monitoring, which integrate information from sensors, appliances, computers, and smartphone, leading toward a highly distributed intelligent system capable of communicating with other devices and human beings. Also, we're trying to enhance CGA to improve the outcome and uptake. So we're looking to provide an acceptable and accessible intervention. Usually older people with social deprivation or those who live in rural areas have problems with access to CGA. So we're looking to enhance their access to the CGA and to increase the uptake of the assessment. So our research question is, how can comprehensive geriatric assessment of older people with a frailty be enhanced in non-hospital settings? As we said, the primary care setting, the community setting. So to be able to do that, we're aiming to explore the barriers and facilitators to implementing the enhanced CGA, the important outcomes for older people, families, health and care professionals, also to explore the potential for enhanced CGA to exacerbate health inequalities, the impact of differences in digital access, literacy, and how might this best be mitigated against. To contribute to our initial program theory and logic model for an enhanced CGA model, incorporating decision-making process following assessment. Program theory provide a logical and reasonable description of why the program activities should lead to the intended results or benefits at the end. A program theory is a useful way of bringing together existing evidence about the program that we gained some of it by stakeholder engagement, and clarifying where there is agreement and disagreement about how the program is understood to work, and where there are gaps in the evidence that we can address. So, to answer the research question and achieve the objectives, our plan of work involves stakeholder engagement and the 3 work streams. Work stream 1 includes a series of scoping reviews trying to define the enhanced CGA. Work stream 2 is interviews with older people, carers, and healthcare professionals. And work stream 3 is the program theory, as well as the stakeholder engagement. As you can see, the plan is conducted in a cycle rather than a linear one, because each of these work streams will fit into the method of the other work streams, and all the times the findings will be refined by sharing with the stakeholders to see if there is new questions, if there is more needs that we haven't addressed in the research to be addressed later on. What we did in August 2020, we undertook a national online survey of 111 healthcare professionals involved in CGA, including geriatricians, physiotherapists, nurses, GPs. Respondents rated remote delivery as slightly less effective than face-to-face CGA due to communication challenges, particularly for patients with hearing or cognitive impairments, and the inability to conduct effective physical examinations, observations, and investigations. The diversity of older people and family members is fundamental to our research, and we have ensured a wide range of voices have contributed including those with sensory impairment or those speaking different language. What we did and we're doing is stakeholder engagement at every stage of the research. Our patient-public involvement and engagement and health and care professionals have contributed to the development of this research. They highlighted both benefits and the challenges of remote and digital technology, including services being led in primary care or using video may reduce the need to travel to hospital appointments, which may be physically or emotionally difficult for some, especially those who live in rural areas. Using wearable technology would be practical and could help with some diagnosis and reduce clinical time. The ability to record a video consultation help recall what was said, and using a video may enable professionals to see how well person is keeping in their home environment. Also, they said that there are some concerns from all of them about digital access of those living with fragility, especially those with communication difficulties might not be able to have access to technological approaches to care. In addition, our stakeholders felt less confident in the skills of professionals in using technology to undertake assessment, and that some conditions may be less appropriate to diagnose or manage remotely. The first work stream is conducting a series of scoping reviews that led by Prof. Julie Whitney with other members of DREAM team. The intervention development requires evidence synthesis from available literature. Therefore, we conducted this series of scoping reviews to search for novel technological methods to assess gait and balance, cognition, function, observations, and environment. Each review starts with initial researching to draft a protocol that includes the inclusion-exclusion criteria and identify key search terms. Then we started the initial search to explore the topic and to see that if we can refine any key search term or add a new one and create the data extraction form. On the second stage, we undertook pilot searches to explore the quantity and the quality of the articles to be included, ensure that key text have been found. If not, we try to further refine the protocol, the search term according to the pilot search. Then we run the search and start with the screening. The screening usually starts with a pilot screen of around 50 articles by the research team, aiming for 75% agreement between the team members or the different researchers who screen the article. Then we start the screening. Start in 2 stages. First one is title abstract screen. Then after removing any discuss any discrepancies between different researchers and agreed on them, we start with the full text screening. After that, we run the data extraction, usually start with a pilot to pilot the data extraction form. Then we do the full extraction. The analysis and write-up will take the form of narrative writing. Work stream 2 involves semi-structured interviews with stakeholders. It's usually a qualitative study that will inform the development of model of enhanced comprehensive geriatric assessment. Participants are older people, family members, carer, and health and social care professionals. We chose qualitative methodology to allow for in-depth exploration of the intervention and perspectives of stakeholders delivering or receiving the intervention. Until the moment, we have recruited 7 healthcare practitioners from different professionals, including nurses, GPs working in care houses, and physiotherapists. The interviews were conducted using a topic guide. The topic guide was developed in collaboration with the stakeholders. After conducting the interviews, I conduct interviews by myself. After conducting the interviews, it's transcribed and start the analysis. We're aiming to conduct abductive analysis to ensure that we're building on the available literature and evidence instead of duplicating the available evidence. The expected impact from our project is to develop an effective tool for geriatric assessment that utilize technology, integrate the data collected from patients to feed into an intelligent system that can support better clinical decision-making and shared decision-making, allow for better information sharing and communication between healthcare professionals in different healthcare settings. Our future research, we're planning to enhance to evaluate the enhanced CGA. So from this work, we will be able to understand and develop the theory of the enhanced CGA to be implemented and how it could impact on outcomes. So in the future, we will apply for funding to establish feasibility before moving into evaluating effectiveness and cost effectiveness. Also, we have good funding to conduct a national survey of primary care and community-based advanced clinical practitioners, roles managing older people and those living with frailty in the UK. We plan to do an online survey to know with ACPs to know about how they are and their work, understand the type of work they do, and explore whether they use any technology during appointments with older people, explore how technology might be useful or not in the future. We will develop the survey in discussion with older people, their families, and health and care professionals to make sure we include the questions that are important to them. I'll take the chance to say that we're conducting DREAM in collaboration with other universities and NHS Foundation trusts. And thank you all for listening. I leave you, if you have any questions, I leave you now with a brief, Julie with me to answer your questions. If you have any further questions or inquiries, please feel free to contact me on the email. Thank you.